questions. Do you have the time or? So the first ask is, what is AEFI? What are the causes? What are the cause-specific types of AEFI, and what are the types of AEFI based on severity? Tilakavati, can you answer this question?
Any untoward reaction following vaccination that may not be related to the vaccine.
Yes.
Or due to the vaccine property itself.
It could be just a causal, just a temporal relationship with the vaccine. Yes. What are the cause-specific types? Remember, what are the cause-specific types of AEFI?
Vaccine product related, quality related.
Vaccine product related. In
immunization program related, anxiety and coincidence.
Related and a coincidence.
Yeah, we'll go to the answer. So adverse event following immunization, any untoward medical occurrence which follows immunization necessarily may not have a causal relationship with the usage of vaccine, but may have a temporal relationship with the administration of the vaccine. The cause-specific types may be vaccine product-related reaction, wherein you have a where there's a reaction is probably because of the inherent quality of the vaccine itself, like the presence of some ingredient in the vaccine, which can cause the reaction, and vaccine quality defect or related reaction, where the vaccine quality is defective, or it may be related to the device itself, the manufacturing device with which vaccine is being administered, and immunization error-related reaction, wherein you may have the way the vaccine is being handled, the way it's being prescribed, or the way it's being administered. So any of these errors can occur in any of these processes. And immunization anxiety-related reaction. This is when a patient becomes very anxious and gets a reaction following the immunization. So what are the types of AEFI based on severity? So one is serious AEF. Serious AEFI is when a patient gets hospitalized or dies following an administration of the vaccine, may have a constant, maybe having a permanent disability. This is a serious AEFI. In severe AEFI, it is probably because of the side effects the vaccine has produced, which may be in the form of high-grade fever or swelling of the joint, which is usually disproportionate to the the joint gets involved, very much swollen, and the fever is usually very high in this condition. This may be attributable to the vaccine itself. And minor AEFI, the usual reactions which we see, like minor fever and small indurations on the vaccination sites. Okay, so let's go on to the second OSCE. So a 9 months old infant develops erythematous rash, urticaria, and lip swelling immediately following routine MMR vaccination. Also has bilateral wheeze with decreased breath sounds. What is the diagnosis? How will you manage the child? And whom will you report first about the incident? Raghu?
This is an AEFI, anaphylactic. I think it is an anaphylactic reaction following vaccination. We can manage by giving adrenaline, 0.01 ml per kg. One is a 10,000 concentration, IM. And I'll report this to the district immunization officer.
Okay.
Within as soon as possible.
So this is actually mentioned in the immunization book 2018 to 2019. Kindly go through the guidelines. You should all be familiar with it. So anaphylaxis following measles vaccination, what's the diagnosis? The answer is anaphylaxis following measles vaccination. You said 1 in 10,000 is 1 in 1,000 solution of epinephrine, 0.01 ml per kg per dose, intramuscular in the anterolateral aspect of the thigh, secure IV access, and give high flow oxygen and airway ventilation if needed, and fluid bolus if hypotensive. Intramuscular adrenaline may be repeated after 3 to 5 minutes if required. Oral antihistamines may be given for skin symptoms. All serious AEFI, as you said, should be reported immediately to the nearest primary health center on the district immunization officer. Okay, so we'll go to the SP number 3. So what are the IAP, AC, VIP recommendations of polio vaccines? Prachi, current
Now,
recommendations for the
birth
polio
dose of
vaccine.
birth dose of OPV now, and 6, 10, and 14 weeks of IPV, IM 0.5 ml, and a booster dose at 15 to 16 months, and then at 4 to 6 years.
Okay, what if you don't have
Then we can
the
give,
IPV?
then we have to continue the bivalent OPV. That's
With fractional IPV.
Okay, in a private setup, what do you do, and in a public health facility, what do you do?
in regards to IPV, ma'am, we'll give the fractionated IPV at 6 and 14 weeks. That is 0.1 ml intradermal instead of the IM dose.
Okay, and in a private facility,
If IM is available, then we'll give it at 6 and 14.
as a combination vaccine, no, that is available.
Yes,
It's incorporated. Yeah, hexavalent vaccine is available. So, birth dose of OPV is a must, and only bivalent OPV should be given only if IPV is not feasible, and should be given at a private facility at 6 and 14 weeks. And for fractionated IPV dose, or one dose of IM IPV at 14 weeks, either as standalone or as a combination vaccine. So you should give 2 doses of IPV at 6 and 14 weeks, if available as a regular dose or as a fractionated dose. If only one dose is available, then you probably should give IM IPV as a standalone vaccine or as a combination vaccine at 14 weeks of life. In view of the non-availability of standalone IM IPV, can be administered as a combination vaccine in a private facility, 3 doses at 6, 10, and 14 weeks. If you're starting the IM IPV at 8 weeks, then you give the second dose 8 weeks later. Okay, 2 doses. One, if initiated at 8 weeks, the repeat dose can be given 8 weeks later. So going on to the next OSCE, what is meant by fractionated dose of IPV? Raghu?
It is 1/5 of a regular dose, that is 0.1 ml, given through intradermal route instead of IM route. This was initially made available due to shortage of IPV when they made it during the switch state
because the increasing demand, and
government of
so they found this as effective as intramuscular IPV. So whole dose IPV. So a fractionated dose of IPV is 1/5 of a usual dose, which is 0.1 ml injected via the intradermal route. It is safe, effective, and immunogenic. Can be given alone or at the same time as with any other vaccine. It can be combined. Then going on to the next OSCE. So what are the types of typhoid vaccines available in India? Name the carrier protein used in the conjugate typhoid vaccine. What is the minimum age of administration of conjugate vaccine? And can conjugate vaccine be given along with measles vaccine? Does wave capsule polysaccharide vaccine interfere with the interpretation of the viral test? So 3 questions. First 3 questions can be taken up by Prachi, and the remaining 2 by Tilagavati. What are the types of typhoid vaccine available in India, Prachi?
One is a polysaccharide vaccine, and another one is a typhoid conjugate vaccine.
Okay, good. So name the carrier proteins used in conjugated typhoid.
I'm not sure.
Okay.
Minimum age of TCV is 6 months.
6 months, yes. Can TCV be given along with measles vaccine? Tilagavati? Not sure yet. Okay. Does wave capsule polysaccharide vaccine interfere with the interpretation of viral tests?
Yes, interfere with the viral test can produce anamnestic response.
I think the VA capsule polysaccharide does not. No, only the whole cell vaccine interferes with the viral test. Okay. So types of typhoid vaccines: the VA capsule polysaccharide vaccine and the VA capsule polysaccharide conjugate vaccine. The oral vaccines is not available in India. So what are the carrier proteins? the Pseudomonas aeruginosa, exotoxin A, and tetanus toxoid. These are the carrier proteins. And the minimum age of administration is 6 months. And it can be administered with measles vaccine. In between, there was some clarifications which were they were doubtful about administering measles vaccine, but now it clearly says we can administer it with measles vaccine. And VE capsular polysaccharide does not interfere with the interpretation of viral test. Okay. So, what is the schedule of OSCE? We move on to the next OSCE. The schedule of rotavirus vaccine. Elegavati.
10 and 14 weeks as the primary schedule. And first dose of rotavirus vaccine should be started before 15 weeks. And last dose should be completed before 32 weeks.
Yes.
And it should be given as according to National Immunization Schedule, it will be given as 0.5 ml. 5 drops orally.
Okay.
Along with other.
So all the vaccines they say safe and immunogenic. They are monovalent and multivalent, polyvalent rotaviral vaccines. The minimum age is 6 weeks. Only 2 doses of, if you use a monovalent vaccine, it's only 2 doses at 6 and 10 weeks. If you're using a polyvalent vaccine, it's 3 doses in all at 6, 10, and 14 weeks. And if you are using any, if there is a doubt about what vaccine has been given earlier, whether it is monovalent or polyvalent, then you probably can do all the 3 doses, because you should complete the 3rd dose. You should not miss out on the doses because you're not clear with what rotavirus vaccine the child has already received. So a total of 3 doses should be administered. And the age of recommendation being, the minimum age being 16, and the maximum you can extend up to 32 weeks, and not to administer the vaccine beyond 32 weeks of life. Okay. So what is the schedule of MMR vaccine? Raghu?
Given at 9 months of age, ma'am, at subcutaneous route, 0.5 ml. Second dose can be given at 15 months. First booster at 15 months, and the final booster at 5 years.
Yes. And what about the current MR vaccination campaigns? What do you advise? What is their advice regarding the MR vaccination campaigns? To what age do they give the MR vaccine?
9 months to 15 months.
The MR vaccination campaigns are up to, and they give
15
vaccines to 15 years. So measles containing vaccine should be administered at around 20 to 70 days. And MMR is administered instead of MR at 9 months, 15 months, and again at 12 to 15 months with the second booster at 6 years of age. Additional dose of MR vaccine during MR campaigns for children 9 years to 15 years, irrespective of the previous vaccination status. So what is the, so going into the next OSCE, what is the alternative to rabies immunoglobulin?
Twin trap.
Monoclonal
antibody.
Monoclonal antibody. So what is it? This produced by recombinant technology, and it's a very safe immunoglobulin, and it is also the cost effective and much less side effects. So we have chosen so it is and it's a good alternative to the usual immunoglobulin. What immunoglobulin do we administer before we started off with rabies immunoglobulin?
Human recombinant.
What is the recommended schedule for post-exposure prophylaxis for suspected dog bite?
It depends on the category of wound, ma'am.
Yes.
And
what is the current schedule? Is it the same as how many doses are being advocated?
0, 3, 7, 14 to 28 days, one dose, like 4 doses in total.
One site administration.
So one site intramuscular administration at 0, 3, 7, 14, and 20, 14 to 28. So two sites of intramuscular administration on day 0. You can administer on either deltoids, and one site later on, and a single monoclonal antibody product against rabies is demonstrated to be safe and effective in clinical trials. So you can administer the second schedule is 2 sites intramuscular administration on either deltoid on day 0, and then followed by later on day 3, and day 3, day 14 to 28. So what is the dose of recombinant monoclonal antibody?
3.33 units per kg, ma'am.
3.33 international units per kg, preferably during the first vaccine dose or up to the 7th day after the vaccine has been administered. Okay, how do you infiltrate the vaccine?
As much as possible, infiltrate around the wounds. Rest should be.
If the calculated amount is insufficient, it can be diluted with normal saline. So what are the types of COVID vaccine? Now, at least we should know something about COVID vaccine. Almost we're coming to the end of the session. So are you aware of what types are available?
mRNA
worldwide?
vaccine. mRNA
Yes.
vaccine, viral vector vaccine, that is a Covishield.
Okay.
An inactivated virus, killed virus, that is the Covaxin.
So whole virus vaccine is a live attenuated vaccine. It's a weakened virus which has lost its power to replicate, but which replicate but does not cause the illness. And a protein subunit vaccine which triggers an immune response. It's just a fragment of the protein which can trigger an immune response. And a viral vector vaccine, that is a Covishield vaccine, no? Whatever is given down. Harmless virus is an adenovirus, acts as a vector to deliver the genetic code for spike proteins to cells to produce antigen, which induces an immune response. And nucleic acid vaccine, mRNA vaccines. But the disadvantage of mRNA vaccine is that it has to be stored at very low temperatures of minus 70 degrees centigrade. I think we have come to the end of the session. Thank you. I think all of you did an excellent job. I think they've answered very well, extremely well. Congratulate all the postgraduates who took part in the session. Thank you.
Thank you, Dr. Vasanthi. I think you covered most of the vaccines and gave a good overview of what are the possible questions that they can get in an OSCE. I think if Srinivas can come on, Dr. Vasanthi, you can stop sharing your screen. Dr. Srinivas, yes. Yeah, he's there. And so the next session is by Dr. Srinivas, our pediatric gastroenterologist. I'm sure most of the delegates will be familiar with him. They would have heard some of his lectures and discussions. So we are going to have a session on case scenario on chronic diarrhea. So let's move on to the next session by Srinivas.
Hello, am I audible?
Yes, sir, audible, sir.
Thank you. Thank you for that opportunity. So I've been given this session on chronic diarrhea. So I presume that all of you, when you approach the exam, you're going to have a possibility that you have a child with a chronic diarrhea or a malabsorption with failure to thrive as a possible long case. Or sometimes you may even have situations where you're given a small snippet and it may be part of an OSCE. So what I would plan to try and do, this chronic diarrhea itself is a very, very vast and extensive chapter. And you can have a variety of etiologies contributing to the chronic diarrhea. But let us say, from an exam perspective, you're either going to have one of these two situations. Either a younger child with chronic diarrhea and failure to thrive, or an older child with chronic diarrhea. So our aim when we appear for the exam is to approach the case and ask relevant questions and try and see how to make the best out of it. So with this in mind, I'm going to put up certain scenarios and how we approach it, and keep posting questions to my esteemed panelists, Dr. Tilakavati, Dr. Raghu, and Dr. Prachi. So guys, you're ready for it, okay? So broadly, what I would want you people to adopt is one, everybody should be aware of the various etiologies you should consider in a child with chronic diarrhea based on the age of presentation. So this is some homework that all of you need to do before you approach the exam. The second question that you should ask when you go through the history is it a small bowel or a large bowel diarrhea? The third question that you should ask is it likely secretory or osmotic? The fourth question that runs through your mind is there a significant failure to thrive or not? Fifth, it could be pancreatic malabsorption. Sixth, are there any constitutional symptoms associated with this child with diarrhea? And seventh, should I be focusing on anything specific on the dietary history? Is that also going to be important for this child? Now, I've just picked 7 different points that could run through your mind, which could simplify your approach. That could be useful in your negative history when you take a history with diarrhea. So question to you, Dr. Tilakavati. I'm going to skip the first question in this. I'm going to come to that age-based presentation as the last slide. Okay. So first question for you is, how do you approach a child to find out whether it is small bowel or large bowel diarrhea?
Volume of stools, whether it is large quantity or reduced in quantity.
So you tell me what happens in small bowel, what happens in large bowel.
In small bowel, usually there is a large volume diarrhea.
Okay.
And in large bowel, its volume is much more less.
Okay. So when you're given an opportunity, shoot, keep on going.
Whether it is explosive or not.
Okay.
Presence of mucus and blood.
Where is it there?
There is pain during passing stools. That there is tenesmus that are not. We present in large bowel diarrhea.
Yeah.
And also associated symptoms like a fever.
Okay. So fever can sometimes be present both in small bowel as well as large bowel diarrhea. But yes, I think you kind of summarized it. Small bowel diarrhea tends to be large volume, sometimes only around 4 to 6 times in a day, but it's characterized by the absence of blood and tenesmus. Whereas large bowel diarrhea is characterized by the presence of blood and mucus as well as tenesmus. And it generally tends to be little more small volume than a large volume. So all of these differentiations, we should understand, we should take it with a pinch of salt. But the most important factor here is the presence of blood and mucus as well as tenesmus, which tells you that this is possible large bowel diarrhea. The presence of edema or hypoalbuminemia can be present both in small bowel as well as large bowel diarrhea if there is significant mucosal damage. Okay, so be prepared for this question. How do you know whether it's small bowel or large bowel? Okay, Raghu, can you just go through this and tell me whether this is all small bowel or large bowel diarrhea?
IBD large bowel. Viral diarrhea can be both, but mostly small bowel.
Okay.
Celiac is small bowel.
Yes.
CMPA is small bowel.
Can also be large bowel occasionally because you can have colitis.
Yeah, this is small bowel.
Yes. Okay. So that's for you to at least understand that IBD sometimes can have small bowel involvement as well, but usually the diarrhea, like you mentioned, is due to large bowel. That's okay. So that's just for you to understand small bowel, large bowel diarrhea. Okay. Now, question to you, Raghu. How do you know whether it's secretory or osmotic diarrhea? What history will help you?
The quantity of stools, sir. If it is very large amount of stools, it points to secretory diarrhea. And then the relationship with food. If the diarrhea is stopping with NPO status, like if the child is not having anything and the diarrhea is stopping, it is mostly osmotic diarrhea. If the diarrhea is all through all 24 hours of the day, it is mostly secretory diarrhea. And then we can do stool osmolarity also. If it is the difference between serum and stool is more than 100, it is mostly osmotic diarrhea. If it is less, it is mostly secretory diarrhea. And then,
of all of this, what do you use mostly in your workup when, as a postgraduate, you've seen children?
the relationship to food and quantity of stools.
Okay. So I think the most important thing, you hit that as the first thing. More than quantity, osmotic diarrhea stops when you don't feed the child. In fact, I've written that in bold, and I want all of you to take only that as the most important point. That's the only thing you're expected to say. The rest of it all is a little bit of theory. Though we talk about stool osmotic gap in practice, when we end up calculating stool osmotic gap, it never helps us to diagnose. Okay. So if you keep a child nil by mouth for 12 hours or 24 hours and you don't find anything coming out, then it's quite likely that you're dealing with a child with osmotic diarrhea. Okay. So let's go on to Parachi. Why don't you tell us whether it's secretory or osmotic in these?
The cholera will be explosive stools, osmotic diarrhea, secretory diarrhea, because large volume stools are there. It will be.
What is the differentiation that I told you? The differentiation is, how do you differentiate large volume or small volume? What is important for secretory or osmotic?
In osmotic diarrhea, there will be relationship to food.
Correct. What happens in cholera? What is the reason for diarrhea in cholera? So there is a hyperactivation of your CAMP pathway by the cholera toxin. So it's a toxin-mediated diarrhea. So essentially, even if you keep NPO, the child will keep purging in cholera. That's usually a secretory diarrhea in cholera. What happens in rotaviral?
Secretory. So
yes, it is secretory, but after about 7 days, because of the damage that occurs to the intestine, a small percentage of children with rotaviral diarrhea can develop a secondary lactose intolerance, and that is osmotic. Okay?
Yes,
what happens in celiac disease?
Osmotic.
Yes, because most of it is related to only mucosal damage and lack of villi and inability to digest your carbohydrate. Okay? Yes. And what happens in ulcerative colitis?
That is an inflammatory disease. So
it's an inflammatory diarrhea. So you actually can't put it as either secretory or osmotic. Okay. So all these classifications are helpful in some. They're not helpful in classifying all our etiologies. Okay. So question to you. What are the diarrheas which are associated with failure to thrive? And is there any diarrhea which is not associated with failure to thrive?
So most of the chronic diarrheas would be associated with failure to thrive. For instance, like cystic fibrosis.
No, that's accepted. Okay. I'm asking you only the etiologies which are not associated with failure to thrive, but somebody is having chronic diarrhea.
Okay. Maybe infective diarrhea initially.
Okay. So generally, most of the children who have toddler's diarrhea or irritable bowel syndrome, that is the only condition where you may have a chronic diarrhea, but you don't have any failure to thrive. Otherwise, any chronic diarrhea will result in a significant malabsorption and significant failure to thrive. Okay. So when will you suspect pancreatic malabsorption or maldigestion? What history is important in such children?
The stool will be sticking to the pan or floating in the water, oily stools, and foul smelling stools.
Correct. So the reason why I brought this up is because when we approach a child with chronic diarrhea, usually pancreatic causes never present with diarrhea. So it's very difficult to get a history in somebody who's having lots of diarrhea. Pancreatic, it's a very unusual cause. Usually they just present like he passes lot of stools. They never complain it as diarrhea. These are all large volume, foul smelling, oily stools, like you rightly mentioned. And what is important is if there is isolated pancreatic maldigestion, children may have a very good appetite and oral intake as well. But this does not occur in children with cystic fibrosis, where they may have associated respiratory problems and bronchiectasis, and that may decrease their appetite. Whereas if you have a chronic pancreatitis, which is causing pancreatic malabsorption, then generally the appetite and oral intake is well maintained, but they still pass a lot of stools. So that history you might want to elicit in a child to rule out pancreatic maldigestion. Well done. Tilaka, question for you.
Yes, sir.
Associated constitutional symptoms. This child is presenting to you with fever. So in chronic diarrhea, fever is rather rare. In acute diarrhea, initially for a couple of days, fever is common. So what etiologies run through your mind when you have fever as a symptom?
Infections like
So each of these questions are going to come in your negative history, correct or not? So that's the reason why I'm asking. You're going to ask these questions in chronic diarrhea, right? So they're going to ask you, why did you ask a history of fever?
Immunodeficiency.
Yep. Immune deficiency. Okay. Okay. So inflammatory bowel disease is a condition where you have fever associated with chronic diarrhea, immune deficiency, intestinal tuberculosis. All of these conditions should run through your mind. This is the reason why you're asking for fever or any other constitutional symptom. You can also ask for certain other extra gut manifestations like skin lesions and arthralgia for inflammatory bowel disease. Okay, right. Dietary history, where is it important, Raghu?
Sir, it can be important in food allergies, sir. CMPA will have the introduction.
Very good.
And then toddler's area.
How is it important in toddlers?
No, it is not important. Celiac disease after the introduction of gluten.
Very good. So diet actually is important in all forms of diarrhea, but specifically, like you mentioned, the commonest conditions where dietary history is very important is onset of diarrhea after the introduction of the offending agent. So if you have a child who's exclusively breastfed, you will not suspect celiac disease. And it's very unusual for cow milk protein allergy unless they have been introduced to cow milk protein. Similarly, if you have very rarely a child with a congenital diarrhea like sucrase or isomaltase deficiency, then maybe the dietary history is important. Similarly, if you have somebody with a secondary lactose intolerance, then specifically eliciting that history that the child has a worsening of diarrhea after introduction of dairy products becomes important for your dietary history. So those are the three conditions: lactose intolerance, cow milk protein allergy, celiac, where you may want to specifically pay attention to the diet. Okay. So broadly, now running through your mind, whenever you have a child with diarrhea, you should discuss a differential diagnosis for that child under these at least 6 broad subgroups. What I have mentioned here is certainly not a comprehensive list. Okay. But at least you will know that you have to think about these. Could this be a congenital diarrhea? Could this be infection? If it is infection, is it viral, bacterial, or parasitic? Raghu, can you tell me what infections can lead to chronic diarrhea?
Cryptosporidium infection in HIV, in sometimes giardiasis.
Yep.
And then
you're right. Parasitic infections could include your cryptosporidium, giardiasis, or strongyloidiasis in mostly immune compromised states. Rotavirus is probably the only diarrhea which usually results in a persistent or a prolonged diarrhea. Tuberculosis, though, is rare to present with diarrhea as the sole manifestation, can present with other constitutional symptoms and failure to thrive also. So otherwise, okay, when you talk about immune deficiency, Tilaka, what are the common immune deficiencies which can present with diarrhea?
HIV.
So broadly think about, you're correct. Think about primary immune deficiency, acquired immune deficiency. So primary immune deficiencies will manifest very earlier, whereas the older child, you will have the acquired immune deficiencies presenting to you with immune deficiency causing infections and diarrhea. The other end of the spectrum is immune hyperactivation. And that is the cause for diarrhea in either IBD or autoimmune enteropathy. In allergy, we already alluded to cowbell protein allergy and celiac disease. And then we have a cost of conditions which are mostly seen in the pediatric surgical unit, where they've undergone some form of resection causing short bowel, which can also cause chronic diarrhea, either secondary to necrotizing enterocolitis or some midgut malrotation resulting in a ischemia and gangrene of the small bowel. So try to fit in your etiological subgroups and get a DD based on one of these 6. Now come to the question that Tilaka was waiting for, etiology based on age of onset. So I'm going to put this up, okay? And you have to at least think about this in your DDs. So generally, viral diarrheas causing persistent diarrhea and cowbell protein allergy are very common at the younger age group. In the older age group, we need to start thinking about inflammatory bowel disease. Celiac disease typically tends to occur between 2 to 5 years of age in the onset. So if you can broadly think at least these and discuss in your DD based on your case in the exam, then I think you'll be fine. Okay. So shall we move on to the case discussion with all this in mind? Please remember the normal physiology before we go to the case. Okay. That small intestine is a very important place where various nutrients are absorbed. Depending upon the history, folic acid, iron, calcium, and vitamin D deficiencies, or you will start thinking about small intestinal diarrhea. Jejunum is involved in the digestion of carbohydrates, protein, and fats, and water-soluble vitamins. And terminal ileum is the one that is most important for absorption of vitamin B12 and bile acids. Right. So we presented an 8-year-old girl who's brought us with a history of diarrhea on and off since early childhood. She's not growing as well as her peers, and she's the shortest in her class. The parents are worried that she's easily fatigued and she's got very poor energy levels. So Tilaka, what runs through your mind?
Celiac disease.
Okay. What else? What does short tell you?
She's not growing as well as his peers, shortest in the class.
So what does that mean?
Short stature associated.
Okay.
Growth, affecting the growth.
Correct. So there is a malabsorption, which is causing chronic malnutrition as well as short stature. Okay. Any other condition you will think of? It's only celiac. You stop with celiac.
Cystic fibrosis.
Cystic fibrosis.
Yes.
Immune deficiency.
Yes.
Immune deficiency.
So this is where that etiological slide helps you. Go through each of those etiologies and tell me what all you will think. Then look up the other case. If you can go through, what do we find now? What are the possibilities more than an 8-year-old? Look this up and see what are possibilities. So you have to consider celiac disease, inflammatory bowel disease, intestinal tuberculosis, or even any other acquired immune deficiencies which can present. Similarly, in this etiology, what all will you consider? Short bowel is,
Infection can
it could be a chronic infection, could be an immune deficiency, immune hyperactivation, or allergy. Congenital and short bowel is out of question, correct? Unless and until there is a separate history, correct? Okay. So we'll go on to the rest of the story. She's got 3 to 4 bouts of large volume, yellow, frothy stools. No oily or foul smelling stools that stick to the pan, no blood. Prachi, what is your inference?
We are trying to rule out pancreatic insufficiency.
Correct.
And it is yellow frothy stools, large volume stools means maybe some carbohydrate malabsorption.
Very good. No urgency of stool, no blood.
Small bowel diarrhea.
Correct. So the absence of blood, and what is urgency? Urgency is whenever you have a lot of inflammation in the rectum, people cannot hold their stool. Rectum is normally the place where a lot of stool comes and accumulates. The moment the stool comes and accumulates, you'll be able to hold it for some time. But when people have severe proctitis, like you see in ulcerative colitis, the moment the stool comes there, immediately they will want to go and empty. That's the reason why you have that urgency of stool in large bowel diarrhea where there is a colitis. Okay. So this is possibly a small bowel diarrhea, and Prachi is suspecting that there could be an associated carbohydrate malabsorption because of the large volume and frothiness. Okay. And barbaric man. Raghu, the other relevant history I'm giving you is that there is no associated fever, oral ulcers, or bone pain, no blood in stools, no history of any fissure, no history of any dehydration requiring any hospitalization, no history of any recurrent respiratory infections or coughs. Past history, this child was found to be anemic by the pediatrician and given hematinics, but continues to remain so. And there is a history of a fracture of the right radius after a trip and fall at 4 months of age. Is anything relevant or nothing is relevant?
Sir, anemia is relevant, sir. Anemia, she's anemic, and there's also a history of fracture, which could mean there's a deficiency of vitamin D rickets. This could be a part of rickets. So I think it could still be celiac disease.
What all information do you have out of all of this?
There's no fever, so not probably infection, no infections, no blood in stools.
Shall we put it as unlikely infection or unlikely inflammation?
Okay, sir.
Okay. No blood in stools indicates unlikely
infection. I mean, inflammation.
Unlikely colitis. Okay. No history of recurrent respiratory infections or cough indicates
unlikely immunodeficiency
or even cystic fibrosis. Okay.
Yes, sir.
So now all you have information is that this is a child who is not growing well, is very short, is anemic, and has had possible vitamin D and calcium deficiency.
Yes, sir.
So where do you think is the problem?
Small bowel.
Okay.
Duodenum.
What is the small bowel involved in? Absorption of
carbohydrate, protein, and fat absorption.
B12.
And water soluble vitamins.
Okay. So you've got carbohydrate malabsorption. You've got anemia, which can be either microcytic or macrocytic. So it can be either iron or B12. We don't know. What will tell you whether it is clinically?
Glossitis, hyperpigmented knuckles.
Then goes in favor of
vitamin B.
B12. Vitamin B12 deficiency, you look for glossitis and hyperpigmented knuckles. What goes in favor of iron deficiency?
Pallor, history of milk intake.
Anemia. What goes in favor of iron deficiency? Clinical finding to suspect iron deficiency.
Nail changes.
Koilonychia. So you're expected to look for that to see whether you're looking for iron deficiency anemia. And okay, you have to clinically look for any changes if possible for rickets to see whether there is a nutritional rickets. So clinical examination, this child is less than the third centile in both weight and height, has pallor, koilonychia, finger clubbing, angular cheilitis and stomatitis, broadening of the wrist with genu valgum, an abdominal distension which is mostly gaseous and has poor abdomen muscle tone and has no organomegaly. And perianal examination confirms that there is no fissure or fistula. Yes, Prachi, what do you want to infer?
So the child, height and weight both are less than the third centile. So.
Okay.
And pallor and koilonychia, child is anemic, maybe iron deficiency anemia. Finger clubbing is there. So with the history, and until now, I don't feel it is a respiratory cause. So maybe it is one of the non-respiratory causes of clubbing. So, and angular cheilitis, stomatitis, all of that can also present because of iron deficiency anemia.
So quick question, what GI conditions can present with finger clubbing?
Celiac disease, sir.
Okay.
IBDs.
IBD as well. Okay. Okay.
And there's broadening of wrist and genu valgum, so maybe vitamin D deficiency, maybe rickets, features of rickets.
Okay.
Again, abdominal distension would be a feature of carbohydrate malabsorption,
Okay.
which is gaseous. Poor muscle tone can be because of vitamin D deficiency. Sir.
Perfect.
And no organism.
Okay. Okay. So what tests would you want to order next in this child?
A complete blood count. Sorry.
Tilaka. That's okay. Tilaka.
Complete blood count.
Okay.
Or already there is anemia. Look for hemoglobin levels and red blood cell indices. And also total count. And then peripheral smear.
So if you have any child with chronic diarrhea, what's your baseline investigations that you will order?
Then serum electrolytes.
Okay.
Then blood sugar. Then renal function test. Then liver enzymes. Total proteins and serum albumin.
Perfect. Okay. So usually, of course, we'll have to include RFT. I missed out on that, but you're right. A complete blood count, including a peripheral smear, ESR to look for any inflammation, or sometimes it's raised in anemia as well. Complete LFT and RFT, stool routine microscopy with a pH and reducing substance, and of course, it's important that we look up the growth chart rather than a single one-time calculation of the anthropometric parameters. Okay, so I'll just go on to two more slides as far as investigations goes. So one thing, like I told you, hypoalbuminemia is associated with any significant mucosal pathology. Some tests that you may be asked about in the exam, these are mainly theoretical questions, but you remember that these are not very often used in clinical practice. Are one, a lactose tolerance test, hydrogen breath test, D-xylose test, Schilling test, 72-hour fecal fat estimation, stool alpha-1 antitrypsin clearance. Most of these are basically tests that we do to rule out some form of either a carbohydrate intolerance or to document that there is a small bowel malabsorption. But many of these tests are no longer used. So what tests we use nowadays are clinical suspicion of a particular etiology and directly do the etiology test required for the etiological diagnosis. So if you suspect an infection, look for the infection. If you suspect celiac disease, you look for celiac serology. If you suspect immune deficiency, do immune deficiency workup. If you suspect cystic fibrosis, do specific tests for cystic fibrosis. If you suspect pancreatic problems, you do imaging. And if you suspect any other mucosal problem, we will resort to an endoscopy plus or minus a colonoscopy with multiple segment biopsies. So this child's workup did reveal anemia, hypoalbuminemia, a very huge, highly positive celiac serology. Please read up about diagnosis of celiac disease before you go to the exam, because many of you who are in South India sometimes may not be exposed to celiac disease as a possible cause of chronic diarrhea. So it's important for you to know what is the diagnostic workup for celiac disease. Raghu, will you be able to tell me what is the diagnostic workup for celiac disease?
Yes, sir. After the initial investigations, we can do total serum IgA and tissue transglutaminase IgA.
Why do you do a total serum IgA, Raghu?
Sometimes in IgA deficiency, it will be falsely.
3% of celiac disease children are known to have isolated IgA deficiency. So sometimes you may miss. So then what do you do if the IgA is low?
We can do EMA, HLAT, HLAT, TS4, I forgot, sir.
Okay.
And we can also do colonoscopy.
Why will you want to do colonoscopy?
The evidence of villus atrophy, we can grading.
So where are the villi present in the intestine? Part of the intestine has a villi present.
Jejunum and ileum.
So do an endoscopy or a colonoscopy?
Endoscopy, sir.
Yeah. So
endoscopy, sir.
Most of the time our questions come only from your answers. So just okay. I know you meant endoscopy, but you missed and said that as a colonoscopy. That's okay. So that's right. So remember that when you have IgA deficiency, you need to test for IgG antibodies to anti-gliadin. Please learn about celiac disease as to what are all the antibodies that you may test for celiac disease. So there are 3 types of antibodies. One is anti-gliadin antibodies, and then there is an anti-endomysial antibody, and then you do antibodies to trans tissue glutaminase. Okay, so the most commonly used test is the IgA to tissue transglutaminase antibody that is used because it is ELISA. The more difficult test to do is the endomysial antibody test because it is based on indirect immunofluorescence. So you need positive celiac serology. You need positive endoscopic duodenal biopsies plus a positive response to gluten-free diet. All 3 are important for you to make a diagnosis of celiac disease. Okay. So what is the treatment of celiac disease, Tilaka?
Start on gluten-free diet.
What is gluten-free diet?
Avoiding wheat, rye, barley, and oats. And also gluten content of the food should be less than 20 parts per million for gluten-free.
Okay. Can you list, I am the mother of a child with celiac disease. Can you please tell me where is gluten in the diet?
Sir?
I am the mother of a child with celiac disease. So I am asking you, what are all the diet to avoid?
Like meats containing chapatis, then barley, oats,
Okay.
and rice. Right.
Okay. Where else is wheat present? If I stop chapati, is it enough?
No.
Prachi?
all the packed like biscuits or
Yes.
anything that is even oats, because it's manufactured in the same units mostly. So even they'll have some.
Everybody is avoiding the question of where is wheat. Everybody is going after this oats, rye, and barley. I didn't ask Raghu because I thought he will know less of his kitchen ingredients. I asked the girls, but
Okay. That in cakes.
okay.
In
So
biscuits.
basically, remember that gluten is omnipresent today. No, like you rightly mentioned, no, biscuits, cakes, rotis, parathas, pizzas, noodles, samosa, you name it, everything has got gluten. Any bakery product will have gluten in it. So we have to actually look at what all contains wheat. So bread will contain, biscuit will contain, cake will contain, pizza will contain, noodle will contain, samosa will contain, puff will contain, muffins will contain, cakes, roti. So chocolates, even some of those chocolates, some of you have to look at the wafers, they will be containing. So all of them has to be avoided. So that is the most, and you have to basically become a very pure South Indian. Even some of the South Indians eat puri. Even puri will contain gluten. Dalia is also a wheat product. So what is the only roti that these people will be able to eat are basically disease. Initially, will I grow back to normal? He may also have